Good afternoon, everyone. I am Dr. Cao Ronghu, the Director of Dementia Center, Shuanghe Hospital, Taipei Medical University. The Dementia Center commits to promote dementia care and update dementia knowledge for physicians and dementia care team members. We have already had 21 masters contributing to this continuous education program, Frontier in Dementia Research master lectures since last year. In this year, we have a great sponsor from Azai company, and we will continue to invite master to share their experience with us. The master today is Professor Marwan Sabbagh. Professor Sabbagh is the Vice Chair of Research in Department of Neurology at the Barrow Neurological Institute, Arizona, US. He served as a behavioral neurologist in Alzheimer's and memory disorder program in the institute. Professor Sabbagh is a leading investigator of many prominent national and international Alzheimer prevention and treatment clinical trial. He also served on the editor boards of the Journal of Alzheimer's Disease and Alzheimer's and Dementia, Translational Research and Clinical Interventions, and the editor-in-chief of Neurology and Therapy. He is a good friend of Taiwan, and he has visited Taipei before. The title of his talk today is Current and Future Development in Alzheimer's Disease Research and Treatment. Let's welcome Professor Sabbagh. Please.
Thank you, Professor Hu, and thank you with your colleagues in Center for inviting me to give the talk this evening. I'm sorry I cannot be with you in Taipei at this moment. So I'm going to speak to you about the newer developments that are going on that have clinical applicability. As Professor Hu says, this field is changing very rapidly, so it's important for us to know. The first major change that we're facing, which has actually been underway for many years now, but is really kind of taken a life in 2023, is redefining Alzheimer's from a clinical disease. So you all know Alzheimer's disease is a clinical disease, right? Forgetfulness, repeating yourself, getting lost, misplacing objects, to a biological disease. So moving it toward looking at it from the amyloid and tau and neurodegeneration. The reason this is important is that in clinical practice, we have always gone with the clinical disease. We've always said, well, we check their B12 or thyroid and MRI, we do a good physical neurological exam, we're excluding other pathologies. But it turns out the approach of going for a diagnosis of exclusion is very, very inaccurate. And in specialty care, it's only 77% accurate, and in primary care, it's only 67% accurate. So I led a study a few years ago, and what we did is we had patients who were called Alzheimer's disease, Alzheimer's dementia during life, followed to autopsy. We got amyloid imaging proximate to death, and we showed that even experts like ourselves only were right 3 out of 4 times and wrong 1 out of 4 times. So people that we experts called Alzheimer's dementia actually had other things like TDP-43 and other things. So we have to understand that the clinical diagnosis and the diagnosis of exclusion is a very inaccurate diagnostic approach. So that's why there's been a big push to go from a diagnosis of exclusion to a diagnosis of inclusion. And in that approach, we really have to focus on the development of biomarkers and disease-specific biomarkers, which we'll talk about now. And why do we need biomarkers? One of the reasons we need biomarkers is disease-specific biomarkers can improve the diagnostic accuracy. I think I made that from 70+% to over 90%. The other reason we need biomarkers is we know that a lot of Alzheimer's disease is a mixed pathology. So only a third of patients with Alzheimer's dementia have pure plaques and tangles, and they may have other things like other proteins. So we need
Professor Sabbagh?
Yes.
I'm sorry, I interrupt you. Your slide did not move. Can you show the whole screen of PowerPoint?
Yeah.
Oh, okay, okay.
Okay.
Because
So,
okay.
so it has not been advancing? Have you seen this slide or no?
Yeah, we can see the slide.
Okay.
Okay.
Yeah. Okay. So we'll go from this slide here. Okay. So
Okay,
one of the things we have said is that Alzheimer's disease biologically, if we don't use disease-specific markers, the diagnostic accuracy, again, around 70%, and a lot of Alzheimer pathology is mixed with other pathologies. So that's why we need disease-specific biomarkers. And it's important that you understand that historically, we've taken a diagnosis of exclusion. If you use the 1984 ADRDA criteria, we use the approach that Alzheimer's disease was diagnosed or biopsy or autopsy confirmed, but it wasn't until we started to get into the 2011 and then the 2014 criteria. So in 2010 and 2014, International Working Group said progressive amnestic disorder plus any biomarker equals a diagnosis of Alzheimer's disease. And a working group in 2011 suggested that biomarkers were considered advisory but not essential. And it wasn't until the Cliff-Jack criteria of 2018 that we had the first true biological definition of Alzheimer's disease being ATN, amyloid tau, and neurodegeneration. But this has now actually gotten even more precise because now we look at ATN to now include ATN. In 2023, we add S, I, and V, synuclein, inflammation, and vascular. So we're now moving more and more toward a biological definition as Alzheimer's disease as the pathology and not the clinical syndrome. So, So now, and the reason this is also important is not just for a clinical definition or clinical description, but because in order to give the new disease-modifying therapies, we will need to have biomarker confirmation. And what does that look like? Well, the first thing we can say to you is that we've used MRI in the past to exclude other pathologies, stroke, tumor, hydrocephalus. But now with the newer approaches, we want to look at volumetric changes with the medial temporal lobe. So in the left-hand panel, you see the medial temporal lobe on a coronal T1 section showing hippocampal volume loss. So that would be a proxy marker of neurodegeneration. In the right-hand panel, you see some evidence with the green arrow of white matter rarefaction, which suggests that there is a cerebrovascular contribution. So we're now using MRI to quantify these changes, not simply identify them. When we look at amyloid PET, there are 3 amyloid PET agents approved: florbetapeer, florbetabain, and flutamidamol. I want to point out to the upper right-hand side, you see in that panel the gray matter and the white matter are clearly differentiated, but in the on the right-hand side, the gray matter and white matter are blurred. When you see them clearly differentiated, that is a negative scan. If you see them blurred like that, it's a positive scan. So amyloid PET in clinical practice is now starting to be used as a presence of amyloid. We don't do a quantification of it in clinical practice, but we can in research with using the Centiloid scales or the SUVR. The point here is that the amyloid PET would be used to determine that the presence of amyloid. Very, very popular in America to do amyloid PET because it's a very expensive technology. The alternative to identifying amyloid using PET is CSF. And CSF, of course, we do because we understand that biomarkers change in advance of the clinical syndrome. So the clinical syndrome of mild cognitive impairment or dementia are late lagging indicators of disease, not leading indicators. And so by the time the patient presents to your clinic, they actually already have a brain full of amyloid and probably have a lot of tau and start to get neurodegenerative changes as well. So we know that we can detect these things we can detect these changes prior to the onset of symptoms. So if we're using disease-specific biomarkers, we would see amyloid be reduced in CSF. We would see tau go up, and we might see phosphorylated tau go up. And ideally, we'd love to look at things like FDG PET and volumetrics, but those have good. They have fair sensitivity and fair specificity, and so the CSF biomarkers have very good sensitivity and very good specificity. So the three biomarkers that we would look at in CSF are A beta 42, or the ratio 42 to 40, phosphorylated tau, and total tau. These all these biomarkers have been highly validated. I'll show that in the next slide. I will say to you that bedside testing of CSF is relatively easy to do. It's not that complicated. We do it often in the clinic, and we have very good success rate in getting it. I will tell you that there is one platform, the Fujirebio platform, that gives you the 42 to 40 ratio, but I would actually prefer to get the ones that have the three markers, like the Roche Alexis or the Athena. So you have to think about what are the markers that you're going to detect, and then what the platform is. And the reason I say this to you is that we know that CSF has been highly, highly validated with over 200 studies done on amyloid and phosphorylated tau and total tau, with very good effect sizes and very, very good sensitivity and specificity. So when the amyloid goes down, total tau goes up and phosphorylated tau goes up. That's very, very accurate for a diagnosis of Alzheimer's disease and highly predictive of progression. So I will show that here in a second. People ask me all the time, can you use the CSF interchangeably from the PET? And the answer is yes. That is to say that CSF markers and PET markers correspond very well with a kappa score of 0.9. However, remember, on PET, you're only getting one protein, and on CSF, you're getting three proteins. The other thing is that we know that CSF is highly predictive. So according to the ADNI study, if you have amyloid is down and tau is up and phosphorylated tau is up, the probability of progression to full dementia for mild cognitive impairment is 90% in 1 year. So CSF is very predictive. And if you look at this slide, you see that it is not only highly diagnosed and diagnostic, it is highly predictive. If using the Kaplan-Meier survival curve on the right-hand side, you see that the CSF that is abnormal has a high probability of progression, and if it's normal, the low probability of progression. So we know that CSF can be both diagnostic and prognostic. The other thing that we now have coming into focus, of course, is tau PET, fluor tau sapir. I will say to you that tau PET is very expensive, not widely available, and so it's not widely used. I will spend the next few minutes talking a lot about plasma biomarkers, so we'll spend some time talking about that. We now are looking a lot at Lewy body disease, and so we had thought that DAT and SPECT would be the way to go, but now we're looking at CSF with the seed amplification assay, salivary gland biopsy, or skin biopsy. And then we'll look at the neurofilament light. So let me show you now the plasma biomarkers. And we're looking at plasma biomarkers in a lot of different categories. And the fundamental change is that we actually been able to detect amyloid in plasma for a long time, but going back 20 years or more from Steve Yonkin's work at Mayo and Jacksonville. The problem has been is that it tends to be very difficult to show that it has reliability, and it wasn't until they actually made it a ratio of 42 to 40 that it became much more accurate. In this study, you show here that the immunoassay, whether using the Alexis or the mass spec, has very good correlation with CSF. It does have good differentiation of normal to Alzheimer's disease, and has good diagnostic accuracy. With the mass spec, as you see, the accuracies range from 82 to 97%, and for immunoassays, 62 to 79%, and has some correlation with CSF. I will tell you in the United States now, amyloid plasma A beta biomarkers are available and approved. There's just two that are available. One is the Precivity C2N test, and it is a 42:40 ratio with an APOE. And the second one is the one below, which has a 42:40 ratio with and we know that in a certain reference range, if you're above a certain reference range, you're less likely to have Alzheimer's disease. And if it's below a certain ranges, you're more likely to have Alzheimer's disease with a good area under the curve. So that's amyloid 42:40 ratio. In my clinic, we just started ordering it 2 weeks ago, the 42:40 ratio. A lot of people are thinking that 42:40 ratio of amyloid is not really going to be sufficient by itself, and you really got to look at phosphorylated tau. So the things that have changed, of course, in the last 20 years is not just the fact that you have to look at a ratio of 42:40. That solved the major problem of why there was such huge variations of Alzheimer's, of amyloid disease. But the assays themselves have changed. 20 years ago, the assay sensitivity was in the nanomolar range, a 10 to the -9, but the newer assays are in the 10 to the 12 to 10 to the 15 to the pico to the femtomolar range, and that's why they can detect proteins that were previously undetectable. And when you look at p-tau, you have, of course, the one that's gotten the most attention is p-tau 181, phosphorylated tau 181. We know if you look at different studies, so this on the left-hand side is the MSD platform, the middle is the Simoa platform, and you show very good sensitivity and specificity of differentiating Alzheimer's disease from normal controls using the MSD platform, and it's reconfirmed in the Simoa platform. And on the right-hand panel, you see that if the phosphorylated tau is elevated, the highly predictive of future progression. So p-tau 181 is actually commercially available now, and is available in a couple of diagnostic assays. Again, I've been using this in our clinic for about 3 to 4 months and has been very, very useful. I will tell you that a lot of people are looking already past p-tau 181 to look at p-tau 217. If you look at Oscar Hansen's BioFinder study, if you use a certain cut point, we know that the area under the curve or the diagnostic accuracy is about 0.96 or 96%. And so it very much correlates very well with CSF p-tau 217. And so people think that, and it is highly also predictive of amyloid. So if your cut point is above a certain threshold, you're likely to be also not only detecting the presence of tau, but the presence of amyloid as well. So a lot of people think that p-tau 217 is where the field will end up. This is a slide kind of summarizing where the different biomarkers are. The question isn't whether you would give an amyloid, anti-amyloid monoclonal antibody on PET or CSF. The question is, would you be willing to give a monoclonal antibody just based on blood, or would you want secondary testing? I myself prefer the use of blood for the negative predictive value. So if the test value is normal, you don't do secondary testing, but if the test value is abnormal, then you do secondary testing like CSF or PET. So I think that I am not ready to commit to the idea of giving it strictly for the plasma test to a monoclonal antibody. Now, the one thing we are talking about a lot in the future is how can we incorporate digital biomarkers, and how can we improve the efficiency of the patient experience? So historically, as a diagnosis of exclusion, your patient would come to you, they'd be complaining about a memory issue. You might order an MRI, you might order certain neuropsych testing, you might not be sure what's going on, and then you would, and the diagnostic process might take a long period of time. Where we're seeing now the diagnostic process evolving is very near in the future is that you will make an appointment for your appointment with the specialist. They will send you a link. The link will have to a cognitive test that will be done through an app. That cognitive test would be downloaded into your electronic medical record. If it's abnormal, it would be flagged. You would go ahead and get your blood tests, including amyloid, tau, and neurofilament light. And if it's abnormal, then you go on to get a more thorough evaluation. The point is that we could actually shorten this diagnostic journey very, very rapidly. So I want to now spend a few minutes talking about the therapeutic landscape. You know, we all have lived in the era of the purple dotted line, which is the symptomatic drugs. That's the donepezil, rivastigmine, galantamine, memantine, which are symptomatic drugs but don't alter the disease course. Ideally, we would love to be in the blue line where we can combine the symptomatic and the DMTs, and we're getting, I think, closer finally. So I will say to you, there's been a huge amount of investment in a lot of different treatment programs. This slide represents billions of dollars of investment, just to show you that there's been a lot of failures. So the big discussion of the moment continues to be around the concept of amyloid. And so we used to think of amyloid biology as a very slow unidirectional process, but we now know that it is not the case. If you look at the fact that we now understand that amyloid is cleaved from the APP, amyloid precursor protein, to create the monomeric A beta, we used to think that this is it's a slow unidirectional process, but we now know that the oligomeric species, when the monomeric species is considered to be a nascent protein, and the oligomeric species, and that's considered to be the one that's associated with the microglial activation and the excitotoxicity. And so we understand that that's when the brain starts to react with oligomeric, protofibrillar, fibrillar, and plaque. So the reason this is important is that the concepts that have been espoused are: one, should you clear amyloid or should you reduce its production? And if you look at the left-hand side of the slide, you have to appreciate the fact that we've tried the disease, production inhibitors, the BACE inhibitors, the secretase modulators, the secretase inhibitors, and they have not succeeded. But the monoclonal antibodies and the amyloid clearing approaches have succeeded. And then we also are looking at new concepts of trying to target tau, receptor activity, and other things. So the first trial of a treatment against amyloid started in the late 90s. Dale Schenk conceptualized or posited the idea of let's immunize a patient against amyloid, with the idea that if you did it, you treat amyloid like an infection, and that you would create antibodies that would remove it. And so the first vaccine, AN1792, was created. And 22 years ago, if I had given you this talk, I would have shown you this Nature paper by Dave Morgan and company showing that you could remove amyloid and do it very, very robustly. So the AN1792 study enrolled in their phase 2 trial 360 patients in 6 weeks. That was the fall of 2001. By January of 2002, we were hearing about problems, and by March of 2002, they stopped the study with 18 cases of encephalitis and 5 deaths. And that sounds pretty upsetting, but then here you see the nickel paper showing you that the amyloid was cleared. And if you look at the cases, clearly, you see less amyloid in the approach. And the fundamental issue with active immunization has been the immunogenicity. You cannot modulate or regulate the immune system once you've turned it on. So that's why they went from active immunization approaches to passive immunization approaches, and that's when the monoclonal antibodies started. I do also want to tell you, though, active immunization approaches, ACC01 and the AC Immune programs, are still trying the idea of immunizing against amyloid, and so we might see these come back to the clinic in the near future. So the first one that was looked at was bapineuzumab. I remember this because I was on the steering committee of this and on the New England Journal paper. What they showed in their phase 1 trial, that they used 5 and 10 milligrams per kilogram, they could remove amyloid in the phase 1 and 2 trials. On that upper left-hand panel is reversed. Sorry about that. But if you look on the lower left-hand panel, you see that amyloid was clearly reduced, was clearly removed. It was the first time ever we could show we could remove amyloid. But by the time we got to the phase 3 clinical trial, as you see in the right-hand panel, the placebo group and the treatment group laid right on top of each other. And people say, well, that amyloid approach doesn't work. Well, I will tell you again, I was on this paper, I was part of this program, and I will say to you, the fundamental issue in the phase 3 trial is that we reduced the dose 10x. So the phase 1 was 5 and 10 milligrams per kilogram, and by the got to the phase 3 trial, it was 0.5 and 1 milligram per kilogram, because we were afraid of something that we now call ARIA. We had never heard of it before, we had never seen it before, and that was what got us scared, as looking at ARIA. So that was bapineuzumab. At the same time, and that, by the way, bapineuzumab targeted the mature forms of the senile plaque, whereas at the other end of the biological spectrum, solanezumab, a monoclonal antibody that targeted the monomeric forms of A-beta, had very, very good safety signals, but did not remove amyloid because the PET never showed any biological signal or biomarker signal, and showed just a scarce, small amount of a clinical efficacy signal that ended up being the effect size that they, for Expedition 1, Expedition 2, and Expedition 3, in aggregate, the effect size was 11% slower compared to placebo, but the company felt like that was not sufficient enough to warrant an approval, and so they stepped away from it. As you know, they reported out the A4 study in 2023 after they had increased the dose of solanezumab significantly, and again showed in the prevention paradigm space that solanezumab had no clinical effect in reducing the trajectory for the development of Alzheimer's disease, dementia, or mild cognitive impairment. But we know we can do it. We can remove amyloid. We can do it well. If you look at the gantenerumab study, this is a study that was published a year ago, showing in the Scarlet Road and Marguerite Road AD study, showed in a dose-dependent manner that you could reduce amyloid. The phase 2 trials used 220 milligrams subcutaneous injection. When they went to the phase 3 trial graduate study, they actually used 1,200 milligrams. So they increased the dose 5x. And yet they showed very clearly that they could remove amyloid, and they did it very well. But the delta, the pre-specified clinical effect was supposed to be 24%, and they only got an 8% clinical signal. And then the company Roche has abandoned gantenerumab, at least in its present form. So we know that we can remove amyloid. The thing that got people excited was aducanumab. Now, despite all the controversy you've read about aducanumab, you need to understand that the real excitement is around the fact that in their phase 1 trial called the PRIME study, and you all know, because we all would love to publish papers in Nature, you know, and I know how impossible that is, and publishing a clinical paper in Nature is even more impossible. But if you look at the aducanumab phase 1 trial, the PRIME study, they show in the dose-dependent manner on the left-hand side, the higher the dose, the more amyloid was removed. That's the panel on the left. On the panel in the middle, they show that the higher the dose, the more slowing in the rate of decline. And you see graphically on the right-hand side in the images that the high dose showed very robust removal of amyloid. This was the first time we saw something called directional concordance. That's to say that the higher the dose, the more amyloid was removed, and the more slowing the rate of clinical decline. Until aducanumab, we either saw a biological biomarker signal or we saw a clinical signal, but we never saw the two both together, and that's why we got very excited about aducanumab. Now they go on to their phase 3. They skip a phase 2 trial. They go straight to a phase 3 trial. This is the Emerge and Engage study, showing very significantly that they could remove amyloid and do it quite well, up to 70%. But their clinical efficacy signal was split. One study, Emerge, was positive, meaning it met its pre-specified endpoint of reducing the CDR sum of the boxes by 22%. But the Engage study was did not meet its pre-specified endpoint. And so the point is that this is one study was positive, one study was negative, and yet the FDA still gave the company approval to release aducanumab. That people thought this was that they were cheating and they made a deal with the FDA, etc. It's not true. What happened is that the FDA made a decision, like they do in cancer, is they said, well, we're going to approve the drug on the fact that it hits a biological target, meaning if you remove amyloid, you've hit a biological target. And they said that the clinical endpoint was indeterminate. So many cancer drugs get approved on the biological signal, efficacy signal, not on the clinical efficacy signal. And that's what the FDA applied to Alzheimer's disease for the first time ever. So the problem has been is that aducanumab was approved more than 2 years ago, but our insurance, Medicare, did not pay for it. So aducanumab was never, ever used in clinical practice. As a sidebar, I will tell you that I have one patient 7 years into her journey on aducanumab and has not progressed, at least not much to speak of. She's still mild cognitive impairment after 7 years. So in my own hands, I've seen some real slowing in the rate of decline. The next drug you need to be aware of course, is lecanemab. This is Leqembi, now known as. What they showed in the phase 2 trial, they did a huge phase 2 trial, 800 patients, and showed that in a dose-dependent manner, the higher the dose, the more slowing in the rate of decline. You see 30% slowing when you got to 10 milligrams per kilogram biweekly, and that the slowing was in the CDR, the ADCOMS, and the ADAS-Cog. And if you see their 201 study, they removed amyloid and they did it very, very robustly. And this is what informed, these two signals is what informed their phase 3 Clarity study, which showed published a year ago in the New England Journal that they showed that on the clinical dementia rating scale, some of the boxes, they slowed the rate decline by 27% compared to placebo. I understand it's not placebo, but standard of care. So all these patients are already on donepezil, rivastigmine, galantamine, in both groups. So we know it's slowing the rate of decline compared to standard of care. So this was a very significant finding. And if you look at the amyloid PET, up to 90% removal within 18 months. And this was, again, a biological signal and a clinical efficacy signal. And if you look at the ADLs, activities of daily living, the slowing the rate of decline by almost 40% slowing in the rate of decline. So this is a very exciting finding. And Leqembi has gone from accelerated approval to full approval in the United States. In Medicare, as now our U.S. Medicare government reimbursement system is paying for it. I will tell you, I already have 12 patients on lecanemab. So let's talk about the DMTs that are starting to emerge, and we will talk about how likely it is. So the drug you need to also be aware of is donanemab. Donanemab, in their phase 2 Trailblazer study, showed that they slowed the rate of decline on their composite measure called the IADRS about 32%. What they were very interesting about the donanemab Trailblazer study is that they actually not only slowed the rate of decline, but they picked patients with intermediate amounts of tau, because they showed that they wanted to select a group of people that are most likely to progress. We know low tau people don't progress very much, and high tau may not respond to drug treatment, so they picked an intermediate tau group and showed very robustly that they could slow the rate of decline 32%. I will say to you, this was published, this is the Minton paper published in New England Journal of Medicine in 2021. Their phase 3 trial, as you know, was announced this year in July 17th, published online at the same time in JAMA. And they showed very, very clearly a lot of very robust efficacy signal signs, including the fact that at 1 year, up to half of the sample did not progress at all. And that their ADL instrument actually had even more robust slowing the rate of decline 40%. And a large amount of the cohort did not progress to the next stage on the clinical dementia rating scale. I will tell you the one thing that was very exciting about the donanemab data is that they actually showed that in the low and intermediate tau populations, they slowed the rate of decline 60%, but in a subset of a population. And they can remove amyloid very, very robustly. We're talking about a highly dynamic removal of amyloid with full clearance within 6 to 12 months where your brain has just no amyloid left. So we know we can do something now that has a biological endpoint. And I thought that the summary paper by David Notman that kind of discusses both donanemab and lecanemab that was published yesterday in Neurology was a very, very useful guide. So donanemab will go in front of the Food and Drug Administration in the United States probably in December and could be released on the United States by January of 2024. I will tell you we need to be aware of ARIA, amyloid-related imaging abnormality. I will tell you that I have had ARIA in my practice. I actually have, of the lecanemab, I have 2 patients with ARIA. We know that the ARIA rates depend on the monoclonal antibody and depend on your APOE genotype status. So I'll show you now that I'll get to that ARIA incidence in a second. Let me come back to that. But people say, well, is it really that you're removing amyloid that causes the clinical efficacy signal, or is it might be a secondary to something else? I think a lot of people would say that it's maybe because you remove amyloid, your tau levels go down, and particularly p-tau 217. And so you see in CSF and in plasma, p-tau levels decrease a lot. And so I will tell you that there is that's likely what is accounting for the clinical efficacy signal. So it's probably the removal of amyloid drives the lowering of tau, and that causes the slowing of the rate of decline. What have we learned about anti-amyloid therapies? You got to go very mild. So mild cognitive impairment, mild dementia. You have to be thinking about your APOE4 carrier status because homozygotes have a high rate of ARIA, and you have to do biomarker confirmation. So if they can't get an MRI, if they have a pacemaker, if they're too impaired, there are a lot of reasons for patients to not get an monoclonal antibody, not that they do get the monoclonal antibody. So ARIA stands for amyloid-related imaging abnormality. There are 2 kinds of ARIA, ARIA-E and ARIA-H. ARIA-H is microhemorrhages, ARIA-E is vasogenic edema. Most ARIA is clinically asymptomatic, meaning the patient's not aware of it. Up to 80% of the time, even the physician's not aware of it. It's an incidental finding. When in about 5 to 10% of the time, it can be symptomatic, a little confusion, a little headache, etc. Now, I will say to you that the ARIA rates depend on the monoclonal antibody and your APOE genotype. So we know if you're an aducanumab, the rates for homozygotes is up to 70%, heterozygotes 45%. And the ARIA rates for aducanumab are much higher than donanemab and lecanemab. In lecanemab, for non-carriers, it's 5%, for heterozygotes, 15%, and for homozygotes, 33%. And donanemab is 12% for non-carriers, 24% for heterozygotes, and 44% for homozygotes. So we do know that ARIA rates depend on your genotype and your APOE carrier status. There are other drugs being developed. As you know, Dr. Cummings, my colleague, publishes what I call the Wheel of Fortune, and there are hundreds, over 120 drugs in development for Alzheimer's disease, not just monoclonals against amyloid. There are small biologics, there's symptomatic drugs, there are neuropsychiatric drugs, there are cognitive enhancers, but this is a very huge area of investment and research interest. A lot of people have said, why don't we target tau? Makes a lot of sense. Well, there's been some challenges, right? So the first thing you have to understand is that you have the issue of trying to get anything across the blood-brain barrier. And then in tau, of course, these are intraneuronal processes. You have to cross into neurons, and that's been a challenge. First thing that has been looked at is microtubule stabilizers or kinase inhibitors. Drugs like lithium and valproic acid have been looked at without any efficacy signal. So the other concept that was looked at is if we know that tau is a microtubule stabilizer, that the microtubules use the tau to bind them, and that when they become hyperphosphorylated, then they become the periodyal filament, and ultimately the cells lyse. So the concept is that these free forms of tau, the extracellular tau, spread from neuron to neuron in a process called preonosis. And the idea is that a monoclonal antibody could bind these free forms of tau to prevent the spread. And it sounded great. And multiple programs have been put into phase 2 trials to see if they can slow the rate of decline. And the answers, for the most part, has been not successful. But we now saw one monoclonal antibody showing a little bit of success, the Laureate study, again, published recently. And so we might still see monoclonal against amyloid, against tau moving forward. There is a new thing that was published, presented this year at the ADPD conference in Gothenburg, looking at an antisense oligonucleotide against tau, and it actually showed that you could reduce tau PET. And so that was very, very exciting. We might see more on that in the future. But targeting tau makes a lot of sense. It just is a biological point. The other thing you understand is that tau correlates very well with clinical progression and amyloid does not. So that's why people think that you should target tau. Now, a lot of people are saying we're going to do combo therapy and we'll do, maybe remove amyloid at the beginning and then put them on a tau stabilizer. There are a lot of things that we might do in the near future. Most people do not realize, of course, that where other drugs have been approved. There's now Sorexevant, the orexin inhibitor, to treat sleep-related disturbance in Alzheimer's disease. There, brexpiprazole has been approved to treat agitation in Alzheimer's disease. We might see specific drugs developed for the homozygotes. We might see other things that are improving synaptic plasticity. There's been a huge focus and shift toward prevention. I already told you about the A4 study. We looked at the Tomorrow study. There's been lots of things looking at autosomal dominant presenile mutation carriers. Down syndrome now is being looked at. And so a lot of drugs are being developed. And this is only a partial list of drugs that are being developed for prevention. That's to say these patients are amyloid positive, not clinically symptomatic, but are starting to develop the pathology with the idea that if you target them prior to the onset of symptoms, you could alter the trajectory by delaying or postponing the cognitive decline. And so with that, I will tell you that Alzheimer's is now in the process of evolving from a terminal disease to a chronic disease, that there are over 100 drugs in clinical trials, and that our diagnostic will, our management of these patients will rely on the objective disease-specific biomarkers. And Professor Hu, I thank you for including me today, and thank you for including me.
Thank you, Professor Sabbagh, your comprehensive lectures. I think it's very timely because the disease-modifying therapy will come to Taiwan maybe next year. So we are preparing to learn more about the clinical trial, especially the disease-modifying therapy. Here is the question: which kinds of diagnosis method and equipment should we prepare before the clinical use of anti-amyloid therapy?
Yeah.
Amyloid PET, tau PET. And you can see the question in the chat.
Okay. So the first thing I will tell you is we would probably want to do CSF or PET. So in Taiwan, I don't know if they're using CSF or PET, but I'm not sure that plasma is sufficient. You would have to do CSF or PET to amyloid PET. I don't think you need both tau PET and amyloid PET. I think you could just do one or the other, and that would be sufficient.
The second question, with longer treatment duration with slower dose of lecanemab, also work to slowing down decline in clinical efficacy signal.
Yeah, very important question. A lot of people have been asking, could you, do a titration schedule, Professor, with the idea that if you slowly titrate up to the maximum dose, you might reduce the complication rate. But I will say to you that the data does not suggest that is. It makes sense from a logical standpoint, but the data does not suggest that. The data suggests that you actually, when you are slow in your titration, you need to remove amyloid. You need to do it quickly. So we need you to get, so the lecanemab had 75 centiloids, gantenerumab 95 centiloids, donanemab 100 centiloids. The target is below 25, and the faster you remove it, the better. So from a logical standpoint, it makes sense from a safety to go slower, but in a biological stand, it is not, that is not hold up.
Okay. We are working on the AUR for DMT.
Good.
So the first question is how can we choose the candidate for treatment? So in you showed the first step, maybe we can use digital biomarker like computerized cognitive test. The second step, we can use the plasma biomarker.
Yes.
And then we go to the CSF or amyloid PET.
Yes.
So okay. So the final you make the decision depends on amyloid PET and or others.
Or
Can
CSF,
you
yes.
treat the patient only based on the plasma biomarker?
So a lot of some people want to go straight to treatment on the basis of a plasma biomarker. So if your amyloid is down and your tau is up, you could go straight to treatment. And I think some people will end up some physicians will end up doing it that way, Professor Yu. But you need to understand that the way the label is written, it just says you have to prove that they have amyloid. So plasma might be sufficient. I just haven't felt comfortable quite yet with the idea of just using plasma to make a diagnostic, a treatment decision. A diagnostic decision, yes, but treatment decision, no.
Okay, thank you. Here is the question from Professor Wang. Any trials targeting moderate or later stage of Alzheimer's disease?
Yes, there are many trials going on to target the later stages. That they are not amyloid directed. So a lot of the amyloid, the conventional wisdom is that amyloid directed approaches only work in the mildest. So we would say to you that I would not pursue those in the moderate severe, but there are a lot of other drugs being pursued, including the gengipane and the other drugs. So yes, there's a lot of drugs in development for it.
Okay. Dr. Huang asked the question on scheduled MRI for area monitoring is hard to arrange. How do you manage this requirement?
So I will say to you that since we have been giving the Leqembi for we put a schedule of MRIs in place. So when we start the infusions, we put the schedule of MRIs in place, including before the 5th infusion, before the 7th infusion, before the 14th. So we just put it as part of our schedule. So if they're getting infusions, by the time they get to the one that they need an MRI, it's already been ordered. So we try to minimize, having a problem if we need an MRI urgently.
Thank you. Okay. Okay. Dr. Professor Li, do you think the cutoff value of plasma biomarkers predicting or excluding possible amyloid positive patients differs between Caucasian and Asian people?
That's a critical question. A lot of people are looking at that very issue. It turns out so far, gender makes more difference than race and ethnic group. But a lot of people want to know that very issue. So if the reference ranges are different for Asians than non-Asians, that would be very important, because you might say it's positive in an Asian and it's negative in a Caucasian. So I will tell you that we don't have a full answer for that question yet, but a lot of people are looking at it. So far, the data suggests it's more gender. The values are more predicted by gender than by race and ethnic group. But that's going to change. That's a recent report out of Neurology.
Okay. Questions from Dr. Lin. In the revised clinical criteria of 2023, it is suggested we should be conservative when interpreting fluid biomarker. Value. You can answer this question.
So values around cutoff point was suggested to interpret as indeterminate. What's your opinion? Is conservative interpretation implied? Yeah, this is I agree with this question, because Professor Hu, when it's very positive, it's easy to make a decision. When it's very negative, it's easy to make a decision. Sometimes there's that intermediate range, somewhere that's not very positive and not very negative, and you have to make a decision as to whether you think that's sufficient to make a treatment decision. I myself as a clinician, I struggle trying to make that decision with that. So I will say to you that for the most part, if I see an intermediate, I either repeat it or I might get more testing. I don't think it's enough to make a treatment decision based on an intermediate determination.
Okay. Professor Wang, the second question. In Taiwan, psychiatrists and neurologists treat patients with AD. Regarding area, do you think new DMTs should be given by neurologists only?
Yeah, so I apologize if I offend anybody on this call or this conference, Professor Yu, but I being a neurologist, I tend to think that for because of the ARIA, I think neurologists should be managing the DMTs. I agree with that comment, and I'm sorry if I offend anybody in this group. I do apologize, but DMT, when you see ARIA for the first time in your practice, it's scary to see it. So you need to have some experience with it. And so, yes, I think as a neurologist, I feel more comfortable with that.
Yeah. Regarding the treatment of tau, we see the donanemab trial. If we remove the amyloid, the tau loading also be reduced.
Yeah.
Why should we treat the tau? Because we just remove the amyloid, the tau will reduce also. So, what are your comments on this point?
I think that's probably the reason that amyloid removal works is because tau levels go down. So the argument is that you don't need to treat against tau because the tau levels go down. That's a very solid, that's a really good argument, Professor Yu. We could just make the argument that just removal of amyloid gives you the dual effects of reduction of amyloid and reduction of tau, and therefore you do not need to do a tau-based approach. And I agree with that. So I could make that argument as well.
Okay, thank you. And regarding the ApoE for genotyping, yeah, in your experience, when ApoE4 homozygous, would you reduce the dose of treatment?
So this is a conversation I have a lot, Professor Yu. I will tell you that I am afraid to give monoclonals to homozygote. There are some of my colleagues that are doing it, to be clear on this. Some people, so one option is you give it, one option is you don't give it at all. One option is you give it on a slow titration schedule. I'm in the middle. I haven't been giving homozygotes because I've been scared to do it. But some people are doing exactly what you're proposing, which is their homozygotes will just go slower on the titration schedule.
Okay. I think the new monoclonal antibody to amyloid can induce ARIA,
Yes.
and also induce the master intracerebral bleeding when the patient receives anticoagulants or the IVTPA in the acute ischemic stroke. Do you recommend exclude this patient with anticoagulants?
Yeah. So there's now the huge discussion as to whether the label for the monoclonals already has a caution about anticoagulation. The discussion now is that not just the caution, but whether you would restrict the use of monoclonals in patients who are on anticoagulation. We know that antiplatelet therapy and the clopidogrel, there's no issue. The question is more about the Eliquis, the Axivan, and the warfarin and things like that. And so again, right now the label is a caution, but a lot of people, especially with the AUR, are saying that they would exclude anticoagulation for treatment.
Okay. So in US, I'm wondering when will you start to treat this patient by MDT commercialized? I mean, right now you have been treating these patients by DMT.
Yes, I have about 12 patients on the DMTs.
Oh, great. Okay. Are there any questions from the audience? Okay. we thanks. Okay, thank you.
Thank you. Thank you, Professor
Because
Hughes.
we are almost, yeah.
Thank you for including me.
Okay, thank you. And we hope you can visit Taipei in the near future.
I would love to.
Thank
I would
you
love
again.
to.
Thank
Thank you
you.
very much. Thank
Bye-bye.
you. Bye.
Bye-bye.